Hi everyone, my name's Haley. I'm a pharmacy resident here at UTMC, and today I'm going to talk about immunosuppressants and which situations you may consider holding them. So the objectives of this presentation is to review mechanisms and kinetics of common outpatient immunosuppressants, discuss some of the risk versus benefits of holding these medications, and which regimens may be affected. So here's a list of your common immunosuppressants. In general, there are a lot of immunosuppressants your patients can come in on, but I wanted to try and concentrate on our transplant population because they're the ones that will be on multiples of these medications and will be on more complex regimens. So of your transplant population, you can have calcineurin inhibitors, antimetabolites, some of your mTOR inhibitors, may or may not have corticosteroids, cytokine inhibitors, and B-cell targeting agents. This slide highlights the calcineurin inhibitors, which includes cyclosporin and tacrolimus. These medications work by inhibiting the phosphatase activity of calcineurin, which inhibits IL-2 and therefore will inhibit T cell proliferation and activation. One of the big things I wanted to highlight was cyclosporin modified versus non-modified. The non-modified is the original cyclosporin. It's a little bit more of an older drug, but it has a more erratic absorption, whereas the modified version is newer and has less erratic absorption and is better for patients overall. Most of the time you will see your patients come in on modified. That is what we use more nowadays, but it's good to note that if a patient with an older transplant comes in, they may be on the non-modified version, and you cannot interchange between the two medications. So you need to clarify with the patient what type of medication they're taking before you proceed. These medications have variable dosing. We mainly titrate to the therapeutic range, which again depends on the time frame from their transplant. So a lot of the dosing and ranges here are just very variable patient to patient. And sometimes it may also depend on what other medications these patients are on. For tacrolimus, if they're also on azathioprine or mycophenolate, we may change the dosing in general. Also, some of the adverse effects of these medications include neurotoxicity, hypertension, some electrolyte abnormalities, and hepatotoxicity. Mainly, tacrolimus has more neurotoxicity, alopecia, and electrolyte abnormalities, whereas your cyclosporin, you'll see more hyperlipidemia, hypertension, and hyperplasia. So this slide lists some of your antimetabolites. So all of these medications work by inhibiting some form of the cell cycle. So starting with azathioprine, it's an analog of 6-mercaptopurine and it inhibits purine synthesis. It can be used in renal transplant, but as well as RA, and so the dosing can vary based on that. Mycophenolate will inhibit a rate-limiting enzyme for guanine synthesis. Leflunomide, I know it's not technically an antimetabolite, but I included it here because it may fit in a little bit more with the mechanisms. It's a pyrimidine antagonist, so it blocks cycling from the S phase to the G2 phase. And then you have methotrexate, which is a folate antimetabolite. All of the dosing can vary just depending on what the indication is. Leflunomide, it's not really used for your transplant patients as part of their regimen, but it can be used for PK polyomavirus, so I included it on this slide. A lot of the dosing is variable as well as the half-lives. Your mycophenolates will have a longer half-life. Of course, leflunomide has the longest here for 14 days. They all will have some sort of anemia my apologies. They will all have some hematologic side effects. So they'll have leukopenia, some will have pancytopenia, thrombocytopenia. So these are some of the medications to watch out for. Methotrexate will have a little bit more encephalopathy, stomatitis. Leflunomide will have more diarrhea, possible SJS. And azathioprine will have nausea and vomiting, some photosensitivity, so these patients have difficulty with sunlight. And azathioprine may be used more for your pregnant patients because it's one of the few that is allowed in pregnancy. So those are your antimetabolites. Here we can take a look at some of your mTOR inhibitors. So what these medications do is that they inhibit mTOR, which is a molecule used for signaling in lymphocytes, macrophages, dendritic cells, but also some of your endothelial cells. So because it has so many different parts of the body that it hits, it has a very diverse side effect profile. Your medications include everolimus and sirolimus. They're mainly used in transplant but can be used in malignancy. As you can see here, everolimus dosing in malignancy is much higher than what you would see in your transplant population. So you just want to make sure that your transplant patients do not have that 10 milligrams a day dosing, and in malignancy they do not titrate to a therapeutic range. So those are some things to keep in mind. The dosing ranges can also vary, just like previously, depending on the medication. For sirolimus, the reference range may be decreased if it's given with cyclosporin, and it may have a little bit more of a tighter range if it's given with tacrolimus and mycophenolate. Some of the adverse effects you'll see with these medications are edema, hypertension, anemia, diarrhea, stomatitis, and impaired wound healing. Corticosteroids, we use these every day in a lot of other different indications. They inhibit glucocorticoid receptor activities, which depletes T cells, eosinophil, apoptosis, macrophage dysfunction, and B cells are actually not inhibited by these medications. The main one you'll see in transplant patients is prednisone. It's usually about 5 milligrams daily, but it can range. Sometimes right after transplant, they may be given 10 milligrams daily. The main adverse effects are osteoporosis, peptic ulcers, hyperglycemia, a lot of your, in general, steroid adverse effects. Sometimes in your transplant populations, they may try to taper to a steroid-free regimen. So sometimes you'll see these in your transplant population, but it really just depends on the patient. The next class is the T-cell co-stimulation blockers. The way these work is that they inhibit the receptor CD28, and that prevents activation of your T cells. These medications include belatacept and abatacept. So belatacept is the main one you'll see in your transplant population. It has a different induction versus maintenance dosing, but that induction dosing occurs at day 1 and day 5, and then weeks 2, 4, 8, and 12. So you may see these patients, if they come relatively soon after their transplant, they may still be on that induction dosing. Maintenance dosing starts at the end of week 16, so again, it may take some time. Abatacept I put on here for completion, but it's not really used in your transplant population. It's mainly used for psoriasis and RA. If you are converting from a calcineurin inhibitor to belatacept, there's actually a separate regimen that patients will be on, but eventually they will get to that maintenance dosing of 5 milligrams per kilogram every 4 weeks. The adverse effects listed here are mainly for belatacept. Because abatacept is more in psoriasis, there are in general a lot less adverse effects associated with it, but belatacept, because we use it in our high-risk population, there's going to be a lot more reported adverse effects. So it can affect your electrolytes, again, hypertension, anemia, leukopenia, some encephalopathy, and some cardiac dysfunction, so AFib. So you really have to watch out in these patients. So now we can get into some of the management of adverse effects in these patients and what to consider for holding doses. For your calcineurin inhibitors, so it'd be your tacrolimus and your cyclosporin, if these patients present with nephrotoxicity, you can consider holding the dose, or depending on the severity, you may target a lower dose, or you could possibly switch to an mTOR inhibitor, just depending on their presentation. If they present with some neurotoxicity, you would also want to monitor the levels, and you could consider switching to an XR formulation. If those patients present with hypertension, we usually manage them with a beta blocker, diuretics, or a calcium channel blocker, rather than changing the dose of the actual calcineurin inhibitor. But we usually avoid ACEs and ARBs about 1 year post-transplant. For mycophenolate, with a lot of the GI complications, there are a few things you can do. You can switch formulations, you can have them take it with food if they aren't already. You can adjust the frequency, so rather than you'd have the same total daily dose, but each individual dose, if you just like increased it, if you increase the frequency but decrease the dose they're getting at each individual time, then that may help overall. And you could, depending on the severity, reduce or hold. A lot of the times, the GI toxicities are more dose dependent and reversible. Um, Azathioprine is also very similar. It has a lot of bone marrow suppression, but is also dose limiting. So you can consider the same um, solutions for that medication. And for your mTOR inhibitors, one of the bigger things you'll see are mouth ulcers, but for those we usually manage with magic mouthwash and cholesterol and triglycerides. We would manage more with fish oil and fibrates rather than actually changing the dose. And just kind of as a note, you could consider a statin in these patients, but statins do have drug interactions with cyclosporin, so you'd have to really use caution and see what other medications they have in their regimen. So some perioperative holding considerations, I know this may come up sometimes, and in general, after reviewing the literature, there's no real definitive answer on what medications to hold before and after a procedure. So I'm just going to try and go through some of the risks versus benefits, what some other institutions are doing, and just some considerations for you to have. So some drugs to consider, some of your medications with longer half-lives, including mycophenolate, your mTOR inhibitors, Sept. If your patient is having an elective procedure, those medications may need to be looked at before the actual procedure happens, maybe a few days to weeks beforehand. Your mTOR inhibitors are the ones that have shown in multiple studies that they do decrease wound healing. So at this institution, we usually hold mTOR inhibitors for all procedures. Some other places may consider switching to a calcineurin inhibitor and may interrupt therapy just depending on the type of regimen. But just so you know, for this institution, we do hold all mTORs for procedures. And also, again, just some things to consider. You may want to look at the full regimen of these patients. Some other institutions may hold mycophenolate if they're also on tacrolimus. Comorbidity considerations. Some of the studies that showed that these patients have decreased wound healing, they also had a lot of diabetic patients, and so in general, they do have decreased wound healing, and it's hard to tell if it's purely due to the medication or their in general comorbidities. Leflunomide, it does have a very long half-life, so if you are concerned about it, you could do a cholestyramine washout. And some consider switching to azathioprine because it does have a shorter half-life and it's a little bit easier to manage around a procedure. But again, we do not do these here. That's mainly at other institutions. I just wanted to show you what other places are considering. Because if these medications are held and they do have some sort of procedure, of course, you're at risk of rejection or flare, and if these patients have a rise in their inflammatory markers, it's really difficult to tell if it's from the surgery, if it's from a possible infection, or if it could be just because of the disease state. Right now, there's really no data on increased length of antibiotics when these patients come out of a procedure, so it would just be difficult to tell what is happening with them. So that is my presentation. If you have any questions or would like to discuss any of this information, please feel free to reach out. You can contact me in the pharmacy or with Dr. Natalie Tuttle. Thank you.